Shim is the Luke and Grace Kim Professor in Cultural Psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis School of Medicine. She's the Professor of Clinical Psychiatry, Director of Cultural Psychiatry, and the Chair of the Vice Chancellor's Advisory Committee on Faculty Excellence and Diversity at UC Davis Health. Dr. Shim received a Master's in Public Health and Health Policy from Rollins School of Public Health at Emory University and an MD from Emory University School of Medicine. She's a member of the Board of Trustees in the Robert Wood Johnson Foundation and the American Association for Community Psychiatry. She serves on the Research and Evaluation Committee of the California Mental Health Services Oversight and Accountability Commission. She serves on the editorial boards of Psychiatric Services, Community Mental Health Journal, and American Psychiatric Publishing, and is a co-editor of the book Social Determinants of Mental Health and the upcoming book Social Injustice and Mental Health, to be published in early 2021. She's a 2018-2019 Fellow of the Executive Leadership in Academic Medicine Program and an at-large member of the National Academies of Sciences, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders. Dr. Shim's research focuses on mental health disparities and inequities, and she provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment Clinic. It's our pleasure to welcome you here, Dr. Shim. I'm sorry it's not in person, but welcome to the internet in Vermont at least. Go ahead.
Thank you so much for that introduction, and it is indeed a pleasure to be with you all virtually today. I'm also very sorry that I'm not presently in Vermont with you all, even though I imagine it's a little bit chilly, so I'm not missing that. So I am very pleased to bring this topic to you today and to spend some time, I hope, discussing and hopefully contemplating some challenging issues that are facing us in mental health. And because these issues are a little bit challenging, I always have to start off with a little bit of a disclaimer. I don't have any disclosures. I'm not affiliated with any drug companies or any other conflicts of interest, a disclaimer. And so I need to explain to you all that this is a difficult and an uncomfortable topic. We're talking about social justice. That leads to an inevitable conversation about structural racism. And so we will be having both of those conversations today. When we talk about topics like this, complex feelings often emerge. They include things like feelings like guilt, anger, resentment, and defensiveness. It may feel at times that I am possibly accusing you of being racist or sexist or any number of other horrible things that one can levy at another. And you also may feel that I have a specific political agenda or that I lack objectivity. I bring up all of these things and I list them as a disclaimer because I have been told that as feedback from many times before. So what I would say is that if you notice any of those feelings emerging in yourself, it is a good time as people that are professionals in the field of mental health. It is a good time to spend that time looking at where those emotions are coming from, taking a little bit of time to do a little bit of self-reflection around why you're experiencing such emotions and what that might mean. And so to help us in kind of processing that, if those emotions come up, I do like to think about this quote by James Baldwin, who said that I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I'm responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason. And so as it relates to that, I would just like to say that the concept of social justice in medicine is a controversial one. This is highlighted by an article that came out in about a little over a year ago in the Wall Street Journal op-ed commentary by Stanley Goldfarb, who was a previous dean of curriculum at the University of Pennsylvania. And his article was really just expressing concern that medical schools are becoming overly focused on social justice issues instead of what he felt was the thing that we should all be focusing on, which is treating illness. And one of the quotes from his article was, "Why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients?" And the other thing that he mentioned in this article is that curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness. And so will many of your doctors in coming years. So he expressed a lot of concern around this idea of the entry of social justice into the world of medicine and into the world of medical education. And again, I think that is an opinion that is shared by many physicians, many other health providers. But I will also say it is a position that has a lot of detractors, including myself. And one of the op-eds in response that was published in the Philadelphia Inquirer by several colleagues at the University of Pennsylvania said that social and health policies have always determined who gets sick and who gets care and where and how. And understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. And I truly do believe that. And I also believe that if we're talking about concepts of social justice, it has such a negative connotation. I think it has so many political implications. And so I do think it's important for us to stop for a minute and define what social justice is. And social justice is based in philosophy. It's philosophical concept. And David Miller was one of the people who helped to define social justice. And generally, his definition is that social justice is the distribution of good or advantages and bad and disadvantages in society, and more specifically, how these things should be distributed in society. So it is concerned with the ways that resources are allocated to people by social institutions. And then John Rawls, another philosopher, added a little bit of additional context to this definition of social justice by saying that it is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. So I think when we define social justice in this manner, it becomes very difficult to disagree with why this would be important. And particularly when we think about taking care of the least advantaged members of society, we're often talking about people, least advantaged members of society end up oftentimes being people with serious mental illness and people with substance use disorders. And so if we are going to think about mental health and providing mental health and taking care of people with mental health problems in our society, I think that we have to come with a lens in which we're considering social justice. And again, when we talk about social justice, we're also going to be talking about structural racism. And I'm going to take some time to define structural racism in a bit. But before I do, I just want to point out that, again, it is difficult to talk about these topics. And one of the reasons why it's so hard is because we have been socialized in our society to believe that it is not polite to talk about race. This starts when we're very, very young. As children, it doesn't necessarily, it's not confined to the United States, but I think it's particularly salient in the United States that children are socialized to think that you're not supposed to comment on somebody's race, you're not supposed to identify somebody's race or connect race to anything. So people are actually quite quiet about these things. In addition to that, health professionals have not been taught about the connection between racism and health. And this starts in medical school. We have a long tradition of teaching concepts of biological determinism, which I'm going to define in a minute. But because we don't spend a lot of time talking about racism and health, instead we talk about risk associated with race, but we never really focus on what the underlying factors are that lead to that elevated risk, and we don't connect how racism affects race. And then the other reason why it's getting kind of difficult to have conversations about these topics is because with the recent protests against racial injustice that happened over the summer, there was a pretty seismic shift in this country to focus on and consider topics related to racism and structural racism. And in that time, I think that many people became a little bit weary about the overemphasis that was taking place around discussions about racism. Some people feel that this is not a topic that should be focused on, and that maybe there's a little bit of an overcorrection happening, that we're spending too much time focusing on this topic. So there are also some additional challenges in thinking about medicine and thinking about health and the ways that we think about race. So One of the big issues that I think we have to think about first is the fact that race is a social and a political construct. It has been created particularly to advance certain social orders and to promote certain political gains, including, for example, slavery. And as a result of it being created in such a sense, it is not something that can be biologically categorized accurately. And it is very interesting because medicine has historically attempted to biologically categorize race and attempted to apply a scientific lens to race without any sort of scientific rigor. Because race cannot be biologically categorized, because it is a social and political construct, because there are no kind of genetic categories, and that we see greater genetic variation within racial groups than we see across racial groups. Because of all of that, it becomes a very rough and imprecise proxy for a number of other things. And those things can include things like culture and genetics and biology and socioeconomic status and many, many other things as well. So what's very interesting about that is that race is this rough and imprecise proxy, and yet in science we rely on it to confirm our assumptions, our prejudices, and our biases about our patients. So we take this proxy, we take this imprecise measure, and then we kind of run with it pretty heavily. And we use that to actually provide poor quality care to people with physical and mental health problems. Here is a quote, and I'm going to read this quote, and then I'd like us to sit with it for just a minute. It's a pretty kind of straightforward thing, but it's also a little bit difficult to hear. So this is a quote from Greer, who said that African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less health care, more disease, and lower life expectancy than whites. If you believe Blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans. And I'm not saying that any of us naturally believe that Blacks are dumb or sick and criminal, but what I am saying is that in medicine, and particularly in mental health, sometimes I think we have stopped looking at the institutional racism explanations for the inferior societal position of African Americans. And many times I think we have erred on the side of saying that the answer for these discrepancies, we haven't bothered to look beyond the answer of maybe there's a natural difference between these populations that leads to these differences in outcomes. And we are quick to kind of move to a more interpersonal or individual explanation for why we see differences in outcomes, or a biological explanation for why we see differences in outcomes. So then the question becomes, how did we get to this point in our society? How did we get here? How do we get to this place where we have these massive inferior societal positions in populations in our country? And this kind of gets to the founding of this country. This goes back 400 years to the idea of when our founding fathers created this country and created the concept of the American dream. This idea that anybody who works hard enough and puts in enough energy, this is the country where if you work hard, no matter who you are or where you come from, you can rise to a level of success in this country. It's just a matter of hard work and believing in yourself. And the really unfortunate thing about this is that American dream was really founded on a lie, which was the idea that we are all equal and that we all have the same opportunities in our life to be successful. And we know that that's just absolutely not true. That in that founding and in that creation of this concept of the American dream, it elevated one group of people and one population above all other populations. And that population that was elevated was white men. And so what happened is that in elevating one population, there was a heavy amount of time that was spent denigrating other populations, or oppressing or marginalizing other populations. And so you started to see that invade the ways that we thought about medicine and the ways that we thought about health and mental health. And so particularly in psychiatry, you saw the rise of pseudoscience, this idea that there were certain conditions that were associated with certain races. And these two conditions were highlighted by, identified and really studied extensively by the physician Samuel Cartwright. And Cartwright had quite a lasting impression on medicine. Many things that he kind of developed or created are still in some form of use today. And so these origins, one of these conditions that Samuel Cartwright first identified and described was the concept of drapetomania. This is a condition in which enslaved Africans had a disease in which they attempted to escape from slavery. So running away from slavery was considered to be a psychiatric illness in slaves. And so drapetomania, he described this condition, and he said, if any one or more of them at any time are inclined to raise their heads to a level with their master or overseer, humanity and their own good requires that they should be punished until they fall into that submissive state which was intended for them to occupy. They have only to be kept in that state and treated like children to prevent and cure them from running away. And the other condition that Cartwright described was dysesthesia ethiopica. And this was a disease of something kind of coined rascality. It was kind of what was considered to be a laziness, a natural laziness that developed in certain slaves, in which they stopped wanting to work and they didn't put out the level of output. I think it's very interesting to consider that that disease in the context that Cartwright described it, because for one, we know very clearly that the output of slaves, the labor put out by slaves in those times was far beyond kind of what was considered to be natural working output. Extreme levels of productivity were coming from slaves, and often in the context of malnutrition and rationing of food that left slaves with poor caloric intake, and yet they had to put out this incredible productivity. And so to connect this concept of rascality or laziness with a disease is actually really quite shocking. But what Cartwright said is that the disease is the natural offspring of Negro liberty, the liberty to be idle, to wallow in filth, and to indulge in improper food and drinks. And so after the prescribed course of treatment, the slave will look grateful and thankful to the white man whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. And so the last thing I want to say about these pseudoscientific medical diagnoses in slaves that were psychiatrically based is that Cartwright had a very specific treatment for both of these conditions, and that treatment was whipping. So I want to take a minute to define health disparities and health inequities, because in my mind, there are two different things, even though we often conflate them. So health disparities are differences in health status among different segments of the population. That can include differences that occur by gender or race or ethnicity or education or income or disability or where you live or any other number of differences. So it's really just describing a difference in health status. And if you notice, there's no value judgment on this difference at all. Health inequities, however, are differences in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. I think it's really important to distinguish these two things, because when we think about differences in outcomes that we see in mental health and substance use disorders, I would say that the overwhelming majority of them, probably 95% of the differences that I am aware of that exist as it relates to mental health are in fact the result of systemic, avoidable, and unjust social and economic policies and practices, and not very much just an intrinsic difference. Just for example, if we look at rates of depression in women, we know that women have higher rates of depression than men in our society. A lot of people like to think that there is some sort of biological explanation for this. We spend a lot of time looking at hormone rates, looking at estrogen and testosterone, and trying to decide if there's some sort of protective or risk associated with these hormones. But we don't spend as much time thinking about the fact that we exist in a patriarchal society and the fact that women have been oppressed for centuries, and also that women are much more likely to be victims of sexual assault and other types of violence. And so that these differences that we see that are highly associated with trauma that we see in depression are very much related to unjust social and economic policies and practices that have created these differences. So again, we tend to try to put the emphasis or the onus on the individual or some sort of internal biological explanation rather than looking at the structures of our society that may have created these differences. And so that gets to this concept of the social determinants of mental health. And I think most people are familiar with what this means, but I'll just define it very quickly. It is the societal or environmental or economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And the social determinants of health are prominently responsible for the health disparities and health inequities that we see both within and among certain populations. So I have spent a lot of time, I consider it to be a lot of time, probably about 15 years, thinking about these concepts. Social determinants of mental health was work that my colleague Michael Compton and I spent several years kind of collating all of the data that was available that connected the social determinants of mental health. And then that led inevitably to me thinking a lot more about social injustice and social justice and how it relates to mental health. And that relates to a book that will be coming out in January that I worked on with Sarah Vinson. And the two of these things kind of form a natural progression in my mind, and I'm actually going to explain to you that progression now. So this is a conceptualization by Michael Compton and myself. It's a little bit busy, but it's actually not that complicated to go through. So if we start at the very top of this figure, this is adverse mental health outcomes, but it's also mental health inequities. And so if you look at that kind of end point, then we can go, we can move down the figure, which is actually moving more and more upstream. So the next thing that happens right before the development of adverse mental health outcomes and mental health inequities are risk factors. And they can be reduced options and poor choices, behavioral risk factors, physiologic and psychological stress. And one of the things that we know is that a risk factor is something that precedes a condition and increases the likelihood of the development of that condition. And what I've started to understand as I was doing this work in social determinants of mental health is that if you're intervening at the level of the risk factor, you are intervening too late because the disease process has already begun to set in at this point. And so by the time you're trying to make that intervention, you can't really do that much. Which is very interesting because in mental health and in psychiatry, we spend a lot of time identifying risk factors. We do risk assessments. We do a lot around risk. And again, what I'm starting to understand is that that is too late. So Sir Michael Marmot and Jeffrey Rose call what we need to be thinking about the causes of the causes, or the things that come before the risk factor, the contextual factors that lead to the development of the risk factor. That's where we should be intervening. And Lincoln Phelan called this the fundamental causes of disease. So that is actually the social determinants of health. Those are these things that you see in these 4 boxes, things like adverse early life experiences and discrimination and exposure to violence, low education and unemployment, homelessness and housing and food insecurity and housing insecurity, and then adverse features of the built environment and neighborhood disorder and climate change. So all of those things are the social determinants of mental health as we have considered them. And we also recognize that that is not the full extent of all of the social determinants of mental health. There are many more. But what I have been doing recently in understanding the concept of social injustice and mental health is I've started to come to understand that if you're intervening at the level of the social determinant, you are still intervening too late, that we still need to move upstream, because the thing that actually creates the social determinants of health are in fact social injustice in our society, which is the unfair and unjust distribution of opportunity. And then the things that create that social injustice are the laws that we pass in our society and the feelings that we have, the social norms that we have about how who in our society is worthy of advantage and who in our society is worthy of disadvantage. So if we have fundamental social norms or social ideas about which people are valuable in our society and which people are not, those social norms then lead us to pass public policies, laws, any type of a policy, both at an institutional level or at a community level or at a federal level, that those laws then reflect our values about people and who is worthy of advantage and who is not. And that's what creates the social injustice that we see in our society. So just as an example, we in this country have very strong social norms about people with substance use disorders. We feel generally as a society, we have some thoughts that people with substance use disorders are perhaps morally failing in some way, that there may be characterological problems. It has been reflected in our public policies and the ways that we think about treating substance use disorders, in the fact that our medical system doesn't really do a very good job of treating substance use disorders. It's reflected in the fact that much of our substance use disorder treatment happens in churches and in religious communities. And it's also reflected in the ways in which we treat certain conditions. So if you think about substance use conditions like crack cocaine use or crack cocaine use disorders, you find that throughout the 80s and the 90s, we spent a lot of time focusing on incarceration, on painting people who had crack use disorder or cocaine use disorder as criminals, as dangerous people who were harming both their own children, but also in addition to their children at risk for horrible violence. And we saw this massive rise in incarceration that occurred as it relates to the crack cocaine epidemic. We also saw differential levels of punishment. So higher rates of incarceration and longer sentences for people who were using crack cocaine versus powder cocaine, even though these are the same drug. So you see all these laws reflecting our thoughts about society. And what then happens is this unfair and unjust distribution of opportunity, leading to the mass incarceration of certain people. And that then created those social determinants of health that you see, which then led to risk factors followed by poor outcomes. And I just want to highlight that when we think about that, if you contrast the way that we have placed value on people who use crack cocaine versus people who use prescription opioids, you can see that our social norms are really important here, because we have decided kind of universally as a society that people who use prescription opioids are somehow worthy of more advantages and more in society than people who use crack cocaine. And as a result, we've passed certain laws and we've considered prescription opioid use disorder to be a public health crisis rather than a criminal justice crisis. Okay, that was a lot. And I'm going to go on and make some definitions right now, define some concepts. So we have multiple types of discrimination that can occur in our society. We have legal and illegal discrimination. That legal discrimination is just kind of our traditional Jim Crow laws, things where the law on the books was in fact a discriminatory law. So saying that people can't drink at the same water fountains. Another kind of example of legal discrimination right now are these bathroom laws that we see on the rise as it relates to transgender individuals. Illegal discrimination is the way much discrimination happens today in our society. Many of the things that are considered to be discrimination are in fact on the books, legally legally not something that you can do. So it's illegal to discriminate against many populations and many groups of people. You have overt and covert discrimination. That's pretty obvious, I think. Overt, you know exactly what's happening. You know that discrimination is occurring. Covert is when it's really not overtly clear that there is discrimination happening. And you can see this often. We talk about this in terms of microaggressions, where you're kind of left scratching your head, trying to understand, did that just happen or not? And then there's 3 levels of discrimination. You have interpersonal or individual discrimination. And I would just say that that's where we spend a lot of our time focusing on in society. We talk about the individual interactions that we have with each other. It's the type of discrimination that gets the most press, gets the most focus, gets the most, we hear the most about it. And in fact, it's not the type of discrimination that's the most pernicious or the most problematic. Actually, that's institutional and structural racism. And so we'll go ahead and define those things. So one thing that we need to talk about before we move on to some of the data has to do with certain principles that are associated with social injustice. So the first is this concept of essentialism. That is a belief that there are these distinct and unchanging and natural characteristics that define social groups and facilitate their categorization. So we're basically just saying that there are different groups of people and we're putting people into these boxes. But unfortunately, people don't work this way. You can't actually categorize and cordon off people into certain groups, even as much as we try to do that in medicine. You can't always do that. So shifting to a concept of recognizing that essentialism is not particularly effective is something that we have to do. There's also an erasure of context. There is a failure to consider the socio-historical context when seeking to understand how inequities happen in our society. And I'm actually going to talk about that in just a minute in greater detail. And then finally, you have these 2 concepts of both biological and cultural determinism. Biological determinism is the false belief that racial groups are biologically and genetically different. And again, as I mentioned, this is a concept that can be taught oftentimes in medical school, that there are differences that are biological between racial groups, which again is false. And then cultural determination is somewhat similar. It's a false belief that differences in racial group are solely the result of cultural factors. And again, it kind of goes along with biological determinism. It's a tendency to say that culture is kind of the main reason why we have differences in racial groups, when in fact that's not correct. And it's also important for us to define the different ways that groups can be oppressed. And again, we can talk about this as it relates to all of the many types of groups that are at risk for unjust and unfair distribution of opportunity, and how that can be expressed in oppression. So Iris Marion Young talked about the 5 faces of oppression, and they are exploitation, which is the unequal exchange of one group's of labor and energies for another group's advantage and advancement. And exploitation, of course, very obviously, we can think about that in terms of slavery, but we can also think about that in modern day times in the form of human trafficking. And then cultural imperialism is establishing the ruling class culture as the norm and othering groups that are not part of the dominant culture. And this is this idea that we don't question the norm. So in our society, again, here in the United States, the ruling class culture is white men. And so we often kind of norm all of our data, all of our research to white men. And we kind of look, we don't question if there's any pathology associated with the behaviors of that particular group, but instead we look at other groups and say, if they're not behaving like this particular group, something is wrong with them. And then powerlessness is when oppressed groups lack power or are blocked from gaining power. And I think that the most common way we can think about powerlessness is as it relates to voting, voter suppression, and the lack of representation in office for certain people and certain groups. So preventing people from being able to vote and preventing groups from representing themselves in political structures is how powerlessness often works as a form of oppression. Marginalization is expelling specific groups from meaningful participation in society. We see that most commonly in mass incarceration, but we also see this in mental health as it relates to putting people with serious mental illness in certain asylums. Keeping people kind of cordoned off from other people in society. And then violence, of course, is threats and experiences of both physical and structural violence. Very straightforward, I think, but I will just say that structural violence is not necessarily physical, but it's when harm and any type of harm is done by a group that has power over a group that does not have power. So a very specific type of oppression. So now I think it's important for us to define what structural racism is. It is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. This system defines dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. And it is not something that a few people or institutions choose to practice. Instead, it's been a feature of the social, economic, and political systems in which we all exist. It does not require the actions or the intentions of others. And I just really want to highlight that point. We can all be good, well-meaning people, and we still can have structural racism in our society because it's not a problem of a couple of bad apples. It's not a problem of some individually racist people. And just to hammer that point home, even if interpersonal discrimination was eliminated today, we would still see racial and ethnic inequities because of the persistence of structural racism, because it is baked into the fabric of our society. So let's talk now about social injustice as it relates to psychiatry. There are several ways that we see this kind of coming out in health. And the first one is the war on drugs. I kind of used that as an example earlier, so I don't think we need to continue to talk about that, but you can see how that differential treatment of certain populations and the fact that Black people are more likely to use crack cocaine and white people are more likely to use prescription opioids, you see how that plays out. Residential segregation is, as we know, this concept of redlining and how we still live in extremely segregated communities in the United States. But that when residential segregation was kind of at its peak, when neighborhoods were being redlined and sectioned off, what happened with those redlined neighborhoods is you saw a disinvestment in those communities. And so there were resources that were pulled from those communities, including things like fire and rescue, and also you saw a lack of clinics, health clinics being happening in those neighborhoods. So some neighborhoods were getting all of the benefits of a civilized society, and other neighborhoods were kind of lacking all of those things. And that led to the problems that we see in access, how we have food insecurity and food deserts in our society now, that how we can have whole neighborhoods where people don't have access to any types of healthy things, but particularly whole neighborhoods where people have absolutely no access to mental health services or any other health clinic services. Immigration policy is another example of structural racism. And it's reflected in a number of ways, but the ways I want to talk about it as it relates to mental health has to do with this idea that there are quotas and screening that happens for immigrants that come into this country, and that our policies have been set up to particularly benefit only certain types of populations from coming. Certain people from certain countries are allowed to enter this country pretty freely, and other countries have been designated as places that we don't really want people coming from. And as a result, we create certain quotas and systems. But what we often do with our immigration policies is that we screen out certain people that we consider to be undesirable. They would be perhaps people with psychotic illnesses or substance use disorders or other mental health problems. And so we do not allow people with serious mental illness or substance use problems to come into this country based on our immigration policies. So as a result, you see, we talk oftentimes of the healthy immigrant effect, that immigrants come into this country and they're much healthier for initially as they arrive, but what we don't really talk about all the time is that that's a direct result of our immigration policy, that we're not allowing people to come into the country that have health problems. And then once they're here, we look at those particular immigrant populations and we say, oh, they're doing so much better. They don't have the same incidence or prevalence of these conditions. We tend to think again of a biological determinism or a cultural determinism explanation for that, rather than realize that we're not seeing the full breadth of the presentation of these illnesses in this particular population. And then the Social Security Act of 1935, as part of the New Deal, this was the creation of Medicaid, Medicare, but also Social Security. So the idea that you pay into your retirement, you pay in from working throughout your lifetime, and then when you get to retirement age, older adults are able to retire and have less financial insecurity, less anxiety and stress about their financial situation. And they're also able to pass a little bit of wealth onto their children and to future generations. So this was a really important act for health in terms of addressing issues of poverty and stability around finances. In order to get this act passed in 1935, Southern senators required that it excluded domestic and agricultural workers. And it just so happened that in the South at that time, the majority of domestic and agricultural workers were Black people. And so as a result, they were not allowed those same benefits that everybody else received from Social Security. So they did, in fact, have financial instability and insecurity in the times that they should have been retiring. And then they were also not able to pass that wealth along to future generations. So now let's focus a little bit on mental health, and in particular, so prior to this is work by Jonathan Metzl looking at schizophrenia in a book that he wrote about this called The Protest Psychosis. So at the beginning of, prior to the early 60s, psychiatric assessments, he basically looked at a bunch of records at Ionia State Hospital in Michigan, which was a hospital for the criminally insane. And most of the people that were being treated in this institution were women. And most of the women that were getting diagnosed with schizophrenia were being admitted to this hospital for things like she wasn't able to take care of her family as she should. She can't do her housework. She talked too loudly and embarrassed her husband. So these were the symptoms that were causing certain women to be diagnosed with schizophrenia and brought into this hospital for the criminally insane, where she might stay for a year or 6 months to a year or two, and learn how to kind of reintegrate to society and focus back again on her roles in society. And what Metzl says about this is that perhaps she rebelled against a patriarchal system and a patriarchal diagnosis that allowed white male doctors and her white male husband to be the arbiters of her mental health. However, the most important aspect is that her defiance was interpreted as a symptom, but not as a threat. And I think that's really critical, because prior to the 1960s, people with schizophrenia were not considered threatening, they weren't considered hostile, they weren't considered to be aggressive. So at the time, the common conceptualizations of schizophrenia did not include any of those symptoms of paranoia or aggression or hostility. Instead, schizophrenia was conceptualized as a disease resulting from early life psychological trauma, often committed at the hands of a schizophrenic mother. And then this all changed in the mid-1960s. Right at the time of the rise of the civil rights movement, there was a new disease described by Bromberg and Simon. They called it the protest psychosis. It was a term that they coined to describe a reactive psychosis arising mostly in Black males as a result of the stress of asserting civil rights in the United States. And so Bromberg and Simon likened these symptoms to schizophrenia paranoid type, but they also described hallucinations of African themes, adoption of Islamic doctrine, and promotion of anti-white mindsets. And they basically said that this reactive psychosis was colored by a denial of Caucasian values and hostility thereto. And so what you see are these concepts that I had defined earlier: biological determinism and the erasure of context. Because researchers claim that Black psychiatric patients had higher measures of hostility than white psychiatric patients, and that this stemmed from delusional beliefs that their civil rights were being violated or compromised. And so you saw this large-scale pathologizing of the tenets of the civil rights movement by equating these ideas with paranoid delusions. And it really allowed certain sectors of society a mechanism for removing threats to the status quo and to the caste system that we have in our society, in the name of safety and mental health. And at the same time, you started to see this rise in the description of Black men as being hostile and aggressive. And so as this talk of the reactive psychosis developed, you also began to see ads coming out. And so this was an ad that appeared also in the Archives of General Psychiatry. So the article and the ad came out in the same journal. And you can see that that ad was really this depiction of this man and the concept of being assaultive and belligerent, and the idea that Haldol is a medication that could control aggressive and assaultive behavior. And the other thing that you see is that as a result of these ads, you see a rise in the prescription of first-generation antipsychotics in the United States, specifically for Black patients, and most specifically for Black men. So you saw that these ads were very successful, because even now, Black patients are much more likely than white patients to be prescribed a first-generation antipsychotic, even as widely available and 30 years after second-generation antipsychotics have been pretty much standard of practice. And this is true of my personal experience. I had a patient last year that was hospitalized for his schizoaffective disorder. He was immediately transferred to a community psychiatric facility. And the first thing that the psychiatrist did was remove him from his current medication and start him on high-dose Haldol. And what you see as a result of this is that in the 1980s and 1990s, Black men were diagnosed with paranoid schizophrenia at a rate over 5 to 7 times that of white men. And work by Steve Strukowski and others has shown that as a result of all of that, Black men and Black people in particular are more likely to be diagnosed with schizophrenia than with affective disorders like bipolar disorder or major depressive disorder. That study was done in 2003, but it was then repeated again last year by Gara and other colleagues, including Steve Strukowski, and that was in 2019. So it's tempting for us to say, oh, these things happened in history, and they're not things that we need to concern ourselves with now, but in fact, they are actively happening now as a result of this historical stuff. And so today, Black patients are more likely than white patients to be considered higher risk for violence. They're more likely to be hospitalized involuntarily. They're more likely to be secluded and restrained, and to be administered higher doses of antipsychotics and administered medications against their will. I want to spend just a minute talking about one other study as it relates to mental health care. This is the idea of who gets treatment in our country. So in 2018, and this is data by SAMHSA, 69% of Black adults with any mental illness received no treatment, and it was very similar rates for Latinx adults. 67% did not receive any treatment for their mental illness. With serious mental illness, those numbers are still quite high. 42% of Black adults didn't receive any treatment, and 44% of Latinx adults with serious mental illness received no treatment. And when we talk about this as it relates to substance use disorders, these numbers are very disturbing. 89% of Latinx adults with substance use disorders received no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment. And what's really interesting about this is, again, our tendency to determine what the explanation for these conditions might be. And oftentimes we say things like, oh, Latinx and Black adults have so much stigma around substance use disorders and mental health treatment, and that is the main reason why you see them not getting treatment. Or you say, oh, so that stigma is cultural, or we may also attribute the issue to a lack of insight, a lack of education, wanting to help people understand that treatment is available. But what actually we know when we look at the data, when we ask people why they didn't get that treatment, cost is the most commonly cited reason for not seeking care. And it was twice as often of minimization of symptoms, nearly 5 times as often as stigma. And so cost relates to the fact that we do not have any type of universal access to healthcare insurance, and that mental health insurance is even more complicated. And so access problems are the result of cost and not kind of internal driven forces the way that we think about it. I would also add here that this study didn't look extensively at the role of discrimination in seeking services, but we do know that Black and Latinx patients often experience extensive amounts of discrimination when seeking mental health and substance use care. And I know just from my own personal experience, if I go, for instance, to a restaurant and I am discriminated against, I do not return to that restaurant. And so the idea that we expect people to seek out services when they're not treated properly is also, I think, very concerning. And then I just want to take a minute to kind of relate this to COVID. So we see, of course, this increase in cases and hospitalization and death, and this is data from the CDC. This infographic from the CDC, I think, is very interesting because even though it's it's put together and it has a lot of information, it also points out many of the things that we've already discussed as it relates to cultural imperialism and as it relates to this tendency to think individually about things. For instance, they have these cases here and hospitalization and death rate, and you can see that these are all rate ratios in which the data is being compared to a norm, and that the norm is white and non-Hispanic persons. So each one of these groups and the higher death rates and the higher hospitalization rates are specifically being compared to white people. And again, this is just something that we naturally do. The other thing is that you see these factors that increase community spread and risk are focusing on crowded situations, close physical contact, in closed spaces, and duration of exposure. These are all individual risk factors. Again, not really highlighting as effectively as I think that they should the underlying conditions, which are mentioned at the end of this infographic, where you see that that race and ethnicity are risk markers for other underlying conditions, including socioeconomic status, access to healthcare, and increased exposure due to being frontline workers. So there is a bit of a mention of this, and I do have to compliment the CDC for at least mentioning that, but sometimes that is not mentioned. And I will also just point out that you see in this infographic that Asian and non-Hispanic persons, there's no increase noted in death, but actually that relates to issues that we have in the ways that we don't properly disaggregate data. So we don't look at subgroups within Asian populations. We just kind of lump all ethnicities of Asian people together. And in so doing, there may be differences in death rates. And I think we're quite certain that there are differences in death rates among different subgroups of Asian populations, but we have no way to know that because we don't disaggregate that data. So I think it's much better to look at these cases in the ways that it's presented here, which is looking at death and case rates as a proportionality to the share of the population. So are deaths greater or cases or deaths greater or less than what they should be in the population in that particular racial demographic group. And so as you can see with this data from the COVID tracking project, that for Blacks, for Latinx populations, and for Native American or Indigenous populations, you see that death and case rates are higher than what should be seen proportional, and that white rates have stayed disproportionately low. And also, this is data that came out in JAMA Network Open earlier this year, looking at the rise in depression symptoms that we've seen in COVID during the pandemic, and that we've seen this rise in populations that are more likely to be oppressed and marginalized. And so in a commentary that I wrote related to this article, I talked about the increase in depression rates being attributable to multiple social determinants of mental health, including unemployment, food insecurity, poverty, discrimination, and adverse life experiences, and poor access to healthcare. And so when we think about interventions for COVID, we have to think about addressing social determinants of health, like addressing income, employment, benefits, food insecurity, and all of the many other issues that come up. So in the last few minutes that I have, I'm just gonna talk about where we need to point ourselves to try to address these issues of social injustice and structural racism. So where we are currently is we're in a state of inequality. People have unequal access to opportunities in our society, and we see that reflected in health and mental health. The goal is not, unfortunately, equality. We often think that that's the goal, but equality is when everybody gets the same tools and assistance. It's really focusing on fairness, on what is fair and what is appropriate. And so equality is actually not the goal. We're not trying to make sure everybody gets the same thing because people have different needs. So one of the goals is that we're trying to work towards is equity. It's giving custom tools that address and identify inequality. And as you can see here, it's giving people what they need to be able to break down inequalities and inequities that we see in our society. But equity is unfortunately not the only goal. The second and I think more primary goal is also about justice. It is about fixing the system to offer equal access to both the tools and the opportunities that are needed. And so that is what we need to try to focus on. And there's ways for us to do that, and it includes education and self-reflection, promoting social norms of inclusion, equity, and respect, advocating for racially equitable public policies, and speaking up and taking a stand. And so I'll go through those very quickly. Here are some resources that will be very helpful around education and self-reflection, because we are not taught these things in medical school or in our health professional educational schools and programs, because none of that is being taught. It is incumbent upon ourselves to teach ourselves. And so these are several books that can help start that journey to have a greater understanding of these concepts. I've added this particular list of resources is for people that are not like huge fans of reading hard to read books. I've added books that are easier to read, but I've also included several podcasts that really get to the point of these topics, and a documentary, I Am Not Your Negro, which really highlights how race is kind of perceived within this country. And one of the things we need to do is focus on the concept of cultural humility. That is when we commit to a lifelong process of self-evaluation and self-critique. And I think that is the biggest mindset change that we could work on, is recognizing that we're not going to reach any type of place of competence at any point in our society, that we have to commit to doing this for the rest of our lives and constantly trying to grow and learn in this process. And we also need to desire to fix the power imbalances between providers and our clients. That is huge. I think we have multiple hierarchies in the system that are set up, again, to create this system of structural violence in which people that have power over other people create harm, whether it is intentional or not, create harm to people in less power. And so we need to be kind of vigilant for that and looking for that at all times. And we need to develop community partnerships to advocate within the larger organizations in which we participate. But fundamentally, it's really about those two underlying factors that I mentioned in that earliest conceptualization. It's really about public policies and social norms. And so we need to promote social norms of inclusion, equity, and respect. This is a quote by James Baldwin: "We can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and right to exist." So if we're going to promote inclusion, equity, and respect, we need to enforce social norms of inclusion and equity. We need to educate or legislate to change social norms. What I mean by that is that many people who have social norms in which they believe certain populations are better than other populations, it's mostly a lack of knowledge, it's mostly ignorance. And so many people can just be educated. It oftentimes has a lot to do with the lack of exposure to certain groups. And so education can be very helpful in those instances. And when it's not helpful, it is helpful to use the existing laws to remove people from doing harm if they have positions of power and can commit harm. We must observe and challenge our own implicit biases, which again is lifelong work that we need to do, and again evaluate and break down unnecessary hierarchies, as we talked about. And then advocating for racially equitable policies includes taking action beyond the walls of our clinics, hospitals, and our treatment centers. to advocate for those policies that address the social determinants of mental health, to communicate with elected officials to promote equitable representation, and to form cross-sector collaborations and community coalitions. And so I will end with the point about speaking up and taking a stand. And so these are quotes from two seminal people. John Lewis said that if you see something that is not right, not fair, not just, you have a moral obligation to do something about it. And then Audre Lorde said, when we speak, we are afraid our words will not be heard nor welcomed. But when we are silent, we are still afraid. So it is better to speak. And so with that, I think we have a little bit of time for questions and comments.
Yes, we sure do. Thank you very much, Dr. Shim. That was a wonderful, thought-provoking talk. We have some time for questions. So if folks want to turn your video on, you can ask your own questions, or if you want to put them in the chat, I can read them. So maybe Dr. Shim, if you wouldn't mind unshare. I mean, we can look at you can think of your quotes, and then we can see if folks have questions.
I will just say that I got a direct message that I think is worthy of asking the whole group and commenting on. So I'll just maybe do that. Is that okay?
Sure.
So the question is, considering ethnocentrism of medical education, are medical schools embodying cultural imperialism? I think it's a great question, and I think that that is a big problem. I absolutely think that they are. And I think the work then involves education around undoing that. I think it has been the practice of medicine for centuries that it is a practice of the privileged. And so people that have power have been able to shape the description of what medicine is and to shape what pathology is. And so absolutely, I think that begins to change as we bring more people of different perspectives and different backgrounds and different levels of the hierarchy into the field of the medical profession. I think that's very important.
Hi, Dr. Shim. My name is Marissa Coleman. I'm a clinical psychologist here at the Medical Center, and I actually moved up here 3 years ago from Atlanta, where I worked with your colleague, Dr. Vincent, in private practice. So it was wonderful to see your book coming out. I'm excited for that. And so part of how I practice is through a liberation psychology lens. And so I'm curious if you could speak a bit about how you see, if you do, liberation psychology weaving into some of the response to the challenges that we experience within the mental health field in terms of the social injustice that occurs.
That's a wonderful question. And I would just say, so liberation psychology, I'm actually not an expert on liberation psychology. I do think it is quite an effective method to think about how to bring the concepts of oppression and addressing injustice into clinical practice. But again, it's not something that I was ever taught. So I don't know enough about it. In fact, I would say, Marissa, that you're probably much more expert on liberation psychology than me. I do know that there are certain principles and tenets of liberation psychology that I have highlighted before, particularly the concept of being proximal to a couple of concepts around being proximal to suffering, but also about the idea of making sure that you are kind of operating in the interests of the patient rather than in the interests of the institution. So I think we spend a lot of time kind of thinking about what are the needs of the institution, and we do this again very naturally, right? It's the way that we were kind of trained. And in so doing, we don't always think about what's in the best interests of the patient and the needs of the patient. And so we're not traditionally thought to think about that or to prioritize that. So as a result, for example, in residency, oftentimes we're asked to complete disability paperwork for patients, and A lot of people think, God, that's not like such a waste of my time, right? Because like I didn't go to medical school to teach to fill out forms. But in actuality, that disability paperwork may be the thing that you do that is the most significant thing that you could do to help improve somebody's life. And so that then becomes the primary focus of your job, in fact. So I tend to view that perspective about what are we doing to actually prioritize the health of our patients through liberation psychology. Again, I think you could speak more about it, but I do think it is an answer to trying to move in the right direction.
Thank you.
There's a question in the chat that I'll just read to you. What would you add to the typical comprehensive mental health evaluation questions that will better speak to people's experience or history who have experienced discrimination and invisibility?
Yeah, this is a great question. And I struggle with this because I've been thinking about this for a while and I go back and forth. I do think it is highly important to ask patients about their experiences with discrimination. And I think that it's something that you should be asking all of your patients about. But I also think that it's very tricky because it depends on who's asking and it depends on why they're asking and what the purpose is. And I think that sometimes you have to build a rapport before you can just jump into asking somebody about their experiences with discrimination. But then at the other time, I think that sometimes when you don't ask about people's experiences, they don't feel that they're being heard or that certain parts of their experience are being valued. So the challenge that I have is kind of when to bring this up and when to ask about it. I again have colleagues and other folks that have done more work in this space, and I think I'm much more expert about that. But I do think that we need to start moving into a place where we're just asking. It's much more part of our regular screening process. So what are your experience? Have you had any experiences in which you were discriminated against? Is a perfectly good starting question. And again, I would ask everybody because all of the data that we have around discrimination states that white people and white men also experience discrimination. So there is no particular demographic group that is free from the experience of discrimination. And I would also say that all of our data on discrimination is not on did you actually get discriminated against? It's really about did you perceive that you were discriminated against? And so you don't actually have to have experienced the discrimination as we defined it. You just have to feel that you were discriminated against. And I think that everybody has the ability to have that feeling and to have that experience. And so it should be asked of everybody.
Thank you.
This is a very quiet group.
I know. Other questions, thoughts? Oh, yeah. Yep, Hannah. See a hand.
Oh, hi. I just wanted to add something, a comment. One of the things I've noticed recently in working in my practice, which is mostly psychotherapy and medication management, is that a lot of my female patients don't even realize they're being, that something that contributes to their socioeconomic disparities compared to men is that I hear these stories about, some of the male members of their family catching a break. Someone will say, oh, I can get you a job working in a mechanic's garage, making $20 an hour, or I can get you a security guard position making $17 an hour. And no one's doing that for these women. And so they're making minimum wage if they're lucky enough to be able to work at all. A lot of times they're getting pregnant and so they're not able to even work. And so it ends up being that the only way to socioeconomic success for the women that I work, some of the women I work with or hear about, is to marry a man with money. And that doesn't often work out so well either. So I've just been struck by that, that there's sort of an old boys network, even among some people who are at the low end of the socioeconomic spectrum.
Yeah, and I think what you're describing, I appreciate you sharing those thoughts, and you're describing how privilege works. So when we talk about the distribution of advantages and the distribution of disadvantages in our society, that's you've just defined that. Because what happens is men, the men that you're encountering are, or that they're talking about, are getting these advantages, getting privileges in society, and that's how, again, our society has been structured. So certain people get these benefits. Hey, I have a friend, and a lot of times it's based on a kind of a very minor thing, right? That the person in power sees themselves in that person. They say, oh, that person is like me. They just need a break. Let me help them out, right? That's how power begets power. And so they're less likely to see themselves in a woman. They're less likely to see themselves in a person of color. And so they're less likely to say, here's a break for you. And so those populations don't get those breaks. Or if they do get those breaks, they're much fewer and much farther between. And so that is exactly how the structure is kind of inherently built. And then certain people rise into positions of power, and then they beget that power to people that look like them.
Exactly. And some these women don't even, the women and the men don't see themselves as being able to do a job in a mechanic's garage or, you know, a security guard. It's just not even conceivable. So it doesn't occur to anybody.
Right. I'll just point out, as it relates to that I mentioned one of the resources that I mentioned on that list was the book Caste, The Origin of Our Discontents by Isabel Wilkerson. And I think that book in particular kind of defines this a little bit, how, because we have this caste system in the United States, we've also kind of assigned certain tasks and responsibilities to certain people in the caste. So the idea is that women are much more likely to be domestic workers, for example. And we have never in our society kind of valued domestic work as kind of a regular job. Even though it is in fact a regular job, it doesn't have the same benefits, it doesn't have the same support as any other job, because it's a job that is seen as a job of women. And again, that is just used to kind of maintain the caste structure. So there are many jobs that, for example, African Americans, being at the bottom of the caste, are expected to do and expected to do well. For example, athletics, entertainment, and essential work like driving buses and important work. But these are the jobs that are kind of circumscribed specifically to Black people, and oftentimes Black men. And so as a result of that, if you are you're not necessarily considered for other jobs. You're not considered as someone that could be in a different role, because that is just not what you're supposed to be doing. That's not the work you're supposed to be doing.
All right, well, our time is up. We should probably stop chatting. And thank you very much, Dr. Shim. It was wonderful to hear about your work. We look forward to following you on your publications where we see them. And sorry about the Zoom applause is not as good as it would be in person. So thank you very much.
Thank you so much. I appreciate spending time with you today.
Julie, is the recording of this going to be available somewhere?
The recording is available on the UVM MC network, but it's not available until it gets working again. I tried to put one up this morning and I couldn't get it. So if you want the recording, send me an email and I'll FTP it to you.
Okay, thank you.
Okay, all right. And I see yours, Joe, so I'll send it when I
Thank you.
figure out the Zoom.
Sure.
Thanks.